We are here to recognize and celebrate and educate you guys and come together since March is Multiple Myeloma Awareness Month. So we have partnered up with the Multiple Myeloma Research Foundation. They're a nonprofit organization. They do some really great stuff. And so I kind of wanted to bring somebody in to talk to us a little bit more and share things that so we can learn what MMRF does, as well as just some things happening in the world of multiple myeloma treatments and things like that. So we will stop periodically for questions, but please drop any questions you have in the chat and I will kind of monitor those. And then when we take our little breaks, I will field those questions to Mary.
Great. Thank you so much, Lauren, and thanks, Jessica and Dan, for inviting me here tonight to talk about multiple myeloma with your crew. Really happy to be here. I'm going to go over some general information about myeloma, some general information about different therapies that are available to patients in the newly diagnosed and also the relapsed refractory setting. Then I'm going to go through a couple of things that are really near and dear to our hearts at the MMRF. I'll go a little bit in depth into immunotherapies and also precision medicine. And then at the end, we'll talk about some resources that the Multiple Myeloma Research Foundation has available for myeloma patients. So hopefully you will find this stuff useful. So I'm going to start out talking about what multiple myeloma is. And multiple myeloma is a cancer of the blood. It's a blood cancer, and it actually grows inside the bones in the bone marrow. So the bone marrow is really the blood factory of the body, and all blood cells are grown inside your bone marrow. So you've got red blood cells growing in there, you've got white blood cells growing in there, and you've got platelets growing in there. And of course, red blood cells are the ones that circulate oxygen throughout your body. White blood cells are the ones that fight infection in your body, and the platelets are the ones that help your blood clot when you cut yourself. So all of those things grow inside the bone marrow. Now, what happens with multiple myeloma, which is basically what happens with every cancer, is that one of the cell types becomes altered or mutated and begins to grow out of control. In the case of multiple myeloma, the cell type that grows out of control and causes the cancer is called a plasma cell. And plasma cells are white blood cells that secrete antibodies. So the antibodies, and you can see them here. Can you see my cursor when I'm sort of wiggling it around there? Okay, great. So here's like a plasma cell, and plasma cells normally secrete antibodies. And as you know, antibodies are what attaches to foreign invaders in your body and then helps your body recognize those invaders as foreign and kills them. So what happens in multiple myeloma is that these plasma cells grow out of control and they begin to fill up the inside of your bone marrow, and they secrete many antibodies that are not useful antibodies. They're useless antibodies. They do nothing positive for your body. And they basically just sort of gum up the works, right? You've got a lot of these antibodies floating around in your plasma. So we'll talk a little bit about what actually happens there due to this overproduction of these cells and then overproduction of these antibodies, which in myeloma are called M proteins, right? Just a short, sort of a short version. So multiple myeloma is not an incredibly common cancer. It's the second most common type of blood cancer. It is the most common type of blood cancer in African Americans. There are about 32,000 new cases per year diagnosed in multiple myeloma, and at any given time, about 130,000 folks living with the disease. But myeloma only represents 1.8% of all new cancers in the United States. And it really is a disease of older folks. The median age at diagnosis is 69. However, of course, people get diagnosed at much earlier ages, and they also get diagnosed at later ages. So I'm going to go a little bit here through what are the common signs and symptoms of myeloma based on what we know is sort of the etiology of the disease, right? Cells growing out of control in the bone marrow and secreting all of these antibodies, these M monoclonal proteins. So what happens mainly, like one of the first symptoms that happens when folks have myeloma is low blood counts. So this happens because there's so many abnormal plasma cells growing in the bone marrow that it basically crowds out the production of all the other types of blood cells in the bone. So as we mentioned, the bone is the blood factory of the body. So when you have all of these abnormal plasma cells in there, there really isn't just any room for anything else to grow there. So what happens is you get low amounts of red blood cells, and that causes anemia. Then anemia leads to fatigue and other types of symptoms, fatigue, weakness, and infection. Another thing that happens is a problem with kidney function. Now, that happens due to this really huge amount of these monoclonal antibody proteins, abnormal proteins that are secreted by the huge number of plasma cells. So those proteins are circulating in the blood and they go into the kidneys, and then the kidneys basically get clogged with all of this excess protein, and it begins to decrease kidney function, which is really a very common symptom in myeloma patients. And that causes a generalized weakness of the patients. And also it can cause them to produce less urine. And then really the third big thing that happens with myeloma patients is bone damage. And this affects 85% of all patients. So what happens in the body, in the bones, there's really two main types of blood cells. There's bone cells. There's osteoclasts, which degrade bone, and then there's osteoblasts, which build bone. And normally the activity of these two types of cells is balanced so that there's some degradation, but then there's some building, and then basically your bones achieve sort of a steady state, and you're not losing bone, nor are you gaining bone, right? But in multiple myeloma, when the plasma cells are overgrowing inside the bone marrow, they secrete factors that activate the osteoclasts, which degrade the bone, and then they inhibit the osteoblasts, which build bone. So what happens then is the osteoclasts begin to sort of degrade the bone out of control. And this leads to fractures, which leads to bone pain. And then there's a lot of bone turnover, which means that there's all osteoclasts degrading the bone. And when the bone is degraded, calcium is released into the blood, and that's called hypercalcemia. And that also causes symptoms like loss of appetite and weight loss. So these sort of signs and symptoms lead to what we call symptomatic myeloma, which is defined by these CRAB criteria. So the C, the R, the A, and the B. So C stands for calcium elevation. R stands for renal insufficiency or low kidney function. A stands for anemia or a low red blood cell count. And B stands for bone disease. So as we discussed, there's lesions in the bone that can be detected by x-rays. Another thing that happens in myeloma is that not only are you losing red blood cells, but you're also losing white blood cells because of this overcrowding in the bone marrow, and that causes increased infection. And that's not listed here, but that is also a symptom of myeloma patients. So when a patient exhibits these CRAB criteria, that is really an important part of diagnosing them as having multiple myeloma.
Mary, may I make a quick comment? This is Dr. Dan. Hi, everyone. I'm with Gryt. The other important thing about that high blood calcium is that calcium is one of the things that your heart uses to pump. So really high blood calcium levels are very dangerous because they can cause arrhythmias. So it's really important to monitor that high calcium level and to get it down. And so I'm sure that a lot of you are familiar with things that are done to do that if you have multiple myeloma. So just another important thing there.
Yeah, and so, and you know, one of the things that happens with hypercalcemia also is this sort of like confusion that happens to people. And my mom was diagnosed with multiple myeloma when she turned 80, and it was really that confusion that was due to this hypercalcemia that caused, you know, us to bring her to the hospital in the first place. And that's really how she was diagnosed with the disease. But even despite that, there are a number of patients, like 10 to 20% of patients with newly diagnosed myeloma will not have any symptoms, and their diagnosis will occur because they're going to the doctor for something totally unrelated, and the doctor will do a blood test and will find abnormal levels of protein in the blood, or they will find lesions in the bone. And those are probably the two most common ways that myeloma is diagnosed. So are there any other questions about myeloma biology? Anything else that anybody wanted to ask about that before we sort of get into the whole therapy part?
Not right now.
Okay. Okay. So so there's a lot of therapeutics approved for multiple myeloma. And so this is really the sort of treatment paradigm for newly diagnosed multiple myeloma. Normally, when people are newly diagnosed, they're diagnosed and they're evaluated either as a positive transplant candidate or a non-transplant candidate. And that has a lot to do with their general health. It's not based on their age, but it's based on their general health and whether or not they have a number of other comorbidities like heart disease or diabetes or anything else that might complicate their ability to have a transplant. So if patients are a transplant candidate, they will undergo induction therapy with a triplet regimen. Then they will have an autologous stem cell transplant, which is basically a transplant of their own cells that are removed from their body and then reinfused back in after the myeloma is decreased to a very basal level by the induction therapy. Then they'll undergo a consolidation therapy, and then we'll go on maintenance therapy for a period of time. If a patient is not a candidate for transplant, like my mom wasn't because she was 80 and kind of frail, then you will undergo an induction therapy and then continue on maintenance therapy. The guiding principles of treating multiple myeloma, especially for a newly diagnosed patient, is to use 3 drugs for induction therapy. And that's what we call a triplet regimen. And those triplets will normally include members of different drug classes that are really effective in multiple myeloma. So patients will normally get a proteasome inhibitor, they'll get an immunomodulatory drug, and they'll get dexamethasone. So those 3 drugs will be used for induction. And then what happens is that doctors want to see the patients get a very deep response. So they want to be able to see that the level of myeloma decreases to a very, very low level. And they measure that by looking at the level of protein in the blood, the level of that M protein, and that decreases to a very small level. And they also look at the number of plasma cells in the bone marrow. And that's really sort of a minimal residual disease where they're able to count the number of cells that are still left. And then after the induction therapy, patients can consider a stem cell transplant, and they can either do it upfront or they can wait until later. So stem cell transplant is standard of care therapy, but it really is, it is more and more these days becoming more of a choice than a necessity. And basically, if a patient is newly diagnosed but is a standard risk patient, sometimes they choose to not undergo stem cell transplant right away. They may undergo stem cell transplant after they relapse for the first time. But that's really a choice that patients and their doctors can make together. So again, so there's all these different approaches, regimens. The goals of therapy are individualized based on a patient's age, their organ function, whether or not their disease is assessed as being high risk or standard risk, and other personal factors that may be important to patients. And these are things that are discussed and should be discussed with the care team when patients are newly diagnosed. So almost always, patients are newly diagnosed, they undergo therapy, they undergo stem cell transplant, and then their disease decreases to a very low level, and then they're on maintenance therapy for a period of time. But patients almost always relapse. So, and then they have to go on a different type of therapy. So then the issue becomes choosing the next type of therapy for a relapsed patient. So some factors that go into what therapy is chosen when patients are relapsed are listed here. So it is taken into account what prior therapy was used on the patient and how well did it work. Did the myeloma progress in a short period of time, or did it take a longer time to progress and relapse? Is the patient high risk by various different tests? And then what do we know about this patient? How old are they? What comorbidities do they have? Do they have side effects from previous therapies that are debilitating, such as peripheral neuropathy? And what are their personal preferences or values? So all of these factors go into choosing therapy for a patient who has relapsed. So here's the big list, okay, of main classes of drugs that are available to treat multiple myeloma, both in the frontline setting and also in the relapsed setting. So right now, there's quite a number of drugs that have been approved. 2 drugs have already, let's see, so there's a number of drugs that were approved very recently. So Expovio, which is a novel mechanism of action, was approved back in 2019. As well as, Sarclisa is not listed here, but it should be under the monoclonal antibodies. And that was approved last year. Blenrep was approved at the end of last year, and Pepaxto was just approved a couple of weeks ago. So there's been a lot of new drug approvals recently for multiple myeloma, but there's a lot of choices. So there's, several immunomodulatory drugs, several proteasome inhibitors, and these are the ones that are combined with dexamethasone for the original upfront triplet therapies. And then there's monoclonal antibodies available, and then other drugs that are available that have novel mechanisms of action. So there's a lot of choices. So the ability to make the choice of what particular therapy is the most appropriate for any patient really is a discussion that takes place between the patient and their doctor to really choose what will be the most effective, hopefully, next therapy after the patient has relapsed. So I've reached another breaking point here. Any questions that anybody wants to ask about what we've talked about so far?
Are they doing anything with CAR T cells with my multiple myeloma yet? And where I've read some of that, but I'm not sure if it's just in clinical trials at this point. Thanks.
Well, yes. So I'm going to talk about that during this immunotherapy part, but yes, there's a lot going on in the CAR T world right now. And in fact, there is one CAR T therapy that may be approved at the end of this week on Friday. So we know that the US FDA has given a approval date, which they may or may not keep to, of Friday of this week for approval of the Bristol Myers Squibb CAR T, which is known as BB2121, or right now they're also calling it ide-cel. So that actually may be approved for use this week. But there are a number of other CAR T therapies that are available in clinical trials. So there is a lot of activity in that area right now. We'll talk a little bit more about this when I get into the next section. Any other questions?
Looks like in the chat, Annette said novel mechanism of action is a new term for her.
Okay, so let me just back up one slide. So novel mechanism of action is really just something that's outside what the normal, quote unquote, mechanism of action is. So, and there are drugs that work in a little bit of a newer way than some of the older drugs, like the immunomodulatory drugs or the protease inhibitor. So, for example, Theradac, that was actually approved back in 2015, and it's a histone deacetylase inhibitor. So it works in the DNA of the cell to inhibit the growth of cells. The next one, Expovio, is a selective inhibitor of nuclear export, which basically means that it keeps the myeloma cells, from exporting tumor growth suppressors out of the nucleus of the cell. So the tumor cell knows that these tumor suppressors are going to stop it from growing. So it tries to push them out of the nucleus so it won't affect the way the cells proliferate. But XPOVIO can stop that export out of the nucleus so that those factors remain in the nucleus and help stop the cell from growing. So that's kind of a pretty novel mechanism of action. Now, Pepaxto is a little bit of a different drug too. Pepaxto is actually melflufen, which is the drug that is given to patients who undergo stem cell transplant. It's a very, very potent chemotherapy. And when it's given to transplant patient, it essentially kills all the blood cells in the bone marrow. And so a transplant is when, so patients who are newly diagnosed, they undergo induction therapy, and that kills a lot of their myeloma cells. But before they undergo induction therapy, there's stem cells are collected from the patient. So those stem cells are taken from the patient and they're frozen. And then the patient is given melflufen. And the melflufen is given over the course of the day. And it's such a potent chemotherapeutic that even over the course of a day, it will kill every cell that is present in the bone marrow of a patient. And that includes myeloma cells and also includes any normal blood cells that are in there. So after the patient undergoes that sort of what they call ablation of blood cells in their body, then the stem cells that were removed previously and frozen are thawed and they're infused back into the patient. And those cells are really, really smart and they know exactly where they have to go. They get infused back into the bloodstream and they go directly to the bone marrow and begin to grow. And that's how these patients recover and they get back normal blood cell production. Now, the problem with transplant is that while it does kill almost every myeloma cell, it doesn't kill every single myeloma cell. There's always a few left. So it can be very, very effective, and it can lead to a very long-term remission as the myeloma cells are down to a very, very, very low level. But almost everyone does relapse after that process. So getting back to Pepaxto, Pepaxto is that same medicine, melflufen, but it is given to patients who are triple class refractory in myeloma, meaning that they no longer respond to immunomodulatory drugs, they no longer respond to proteasome inhibitors, and they no longer respond to monoclonal antibodies. So Pepaxto is really the same chemotherapy, melflufen, that has another molecule added to it. And so that melflufen with the other molecule added to it is basically inactive. And it's given to the patient as an infusion, and it is selectively taken up by myeloma cells. Once the melflufen with the other conjugated peptide is taken up into the myeloma cells, that's when the peptide that's attached to the melflufen is degraded and taken off. And then what you have left is melflufen inside the cell, and it kills the cell. So it's really a way of making a chemotherapy, which is very non-selective, into a selective medicine that just attacks myeloma cells by adding that sort of peptide that is conjugated to it. So that's another novel mechanism of action. Any other questions?
Yeah. Why have these aberrant plasma cells learned or evolved in such a way that they no longer respond to the immunomodulatory drugs or the proteasome inhibitors?
It's a common occurrence in cancer, actually. One of the issues with myeloma, as opposed to, say, a breast cancer or a prostate cancer or a lung cancer, is that because it's inside the bone marrow, it can't be removed. It can't be cut out, like you would cut out someone's tumor, right? So it means that it has to be treated where it is. And cancer is actually, you know, when cells become cancerous, cells are very, very, they're programmed to survive. And if they're trying to survive and there's a poison or a therapeutic that is keeping them from growing, they will often, again, mutate and find other pathways that will allow them to continue growing despite the fact that this other pathway that they had been using is now blocked using this therapeutic. So, well, I can't grow this way using this pathway, so I'm going to stop using that pathway and I'm going to start using this other pathway over here to grow. And that's how cells sort of become resistant to therapeutics. And that really is what happens when cells mutate due to therapies that are stopping them from growing. So it's really a genomic process. And cells are just, they're really smart. They want to grow, they're programmed to grow, and they're going to find a way, in most cases, to grow. So what you'll have is myeloma cells that are killed from a certain therapeutic, but there's always another, what they call a clone of cells that becomes resistant to that therapeutic because they've mutated again. And that clone will then begin to grow. And that's what causes the relapse. So that sort of process is known as clonal tides.
Fascinating. Thank you.
Yes, you're welcome. Any other questions? Okay, then we'll just go on to the next section. Let's see what we have. So immunotherapy is a really big area right now in myeloma. So I'm going to talk a little bit about the different types of immunotherapies and how they work. So there's several different types of immunotherapies that are available now, both as approved drugs and also as drugs in clinical trials. So one of the first types of immunotherapies that have become approved for myeloma are monoclonal antibodies. Antibodies like Darzalex or Amplicity or Sarclisa. So these antibodies were constructed to bind to certain proteins that are on the surface of myeloma cells. So these antibodies will bind to the surface of the myeloma cells, and they have several ways of killing myeloma cells. So they actually make the myeloma cells more recognizable as an invader to the patient's body so that the patient's body can recognize them as an invader and then kill them. And they also have their own antibody-mediated cellular cytotoxicity so that they will also, just on their own from binding to a myeloma cell, will also kill the cell. So they work in a couple of different ways. And Darzalex in particular has been very effective in multiple myeloma patients as a therapy. The other type of immunotherapy are these immunomodulatory drugs, which we've already talked about. These drugs activate the immune system in certain ways and allow the patient's immune system to recognize and defeat myeloma cells. The most exciting types of immunotherapy available right now, for the most part in clinical trials for myeloma patients, are CAR T cells, as we mentioned previously, and then these T cell engaging antibodies. So we're going to talk a little bit about those next. They're really very exciting therapies, and we'll talk about how they work. And then in the very early stages, there are vaccines being developed against multiple myeloma. It's going to be quite some time before these vaccines become widely available, even in clinical trials, but they're in some of the very early stages now. And these, they activate myeloma-specific immunity within a patient. So they're basically, they're not vaccines that will make patients immune to myeloma, but they will be given to patients who already have myeloma. So they're therapeutic vaccines and not really immunizing vaccines. So they're a little bit different than, say, the COVID-19 vaccine, which will which will prevent patients from being infected with COVID-19. So they're not quite like that. They're more therapeutic. So let's go on to talk about CAR T therapy, which is really a very exciting area in multiple myeloma right now. And as I mentioned before, we may have our first approved CAR T-cell therapy in myeloma as early as the end of this week. And CAR T-cell therapies have been approved in other types of cancer already. So CAR T stands for chimeric antigen receptor T-cell therapy. So what happens with CAR T is that it helps a patient's own T cells recognize myeloma cells. And this is the one really a big issue with myeloma patients. Myeloma cells are really, really excellent at hiding from patients' immune systems. So a myeloma cell will be present in a person's body, but the person's immune system won't recognize it as an invader, so it won't try to kill it. This type of therapy helps the patient's immune system recognize the myeloma cell as being a foreign invader, and then we'll kill it. So what happens is these cells, T cells, are collected from patients. They are taken from the patient to a laboratory, and they're genomically modified in the lab to be able to recognize myeloma cells. And then they're grown up in a very large number. And then they're brought back to the patient at their academic medical center or wherever they're being treated, and they're infused back into the patient, and they begin killing myeloma cells because they now recognize them. So it's a really interesting process. And the CAR T cells, for the most part, at least the one that may be approved at the end of this week, recognizes a molecule on the surface of myeloma cells called BCMA, which stands for B cell maturation antigen. So that's what you see, this little sort of red scoop here. This is the receptor, and then on the surface of the myeloma cell, you sort of see that red thing sticking out, and that sort of stands for the BCMA. So the CAR T cell receptor on the T cell recognizes this antigen or this protein on the myeloma cell, and so they bind together. And then when the T cell does that, it is able to release poisons, which will then enter the myeloma cell and kill the myeloma cell. And that's how T cells normally stop invaders in your body. So as you can see here on the side, they're genetically modified T cells designed to recognize specific proteins called BCMA on myeloma cells. They get activated once they're in contact with the myeloma cell, and then they destroy the myeloma cell. Once they're infused back into the patient, they can actually last for a fairly long period of time in the patient's body, long enough to really keep the amount of myeloma cells in a patient at a very low level for a long period of time. And it can be up to maybe a year and a half before the patient then begins to relapse. And again, they're created from a patient's own blood cell, but the technology is evolving to develop what they call off-the-shelf varieties. So you would be able to go to the doctor would say, okay, it looks like you need CAR T therapy. Here, let me get this off the shelf, and I will infuse this into you, and these CAR T cells will attach to your myeloma cells and kill them. So this is a very interesting and very unique technology. It's going to be some time before that's ready to go into patients, but for right now, the technology to be able to utilize a patient's own cell to do this has been developed well enough so that the FDA is pretty much ready to approve this in myeloma patients. So here's sort of a schematic of the timeline of how long this takes, right? So first, a patient will go to a CAR T center or a local apheresis center, and they will have the cells removed, the T cells removed from them, and then they return home. During that time, the cells that were removed are sent to the laboratory, and it takes between 10 and 28 days for the laboratory to genomically modify those cells and then grow them up into large numbers. And it really depends on the patient's cells, how fast that takes place and how easy that process is. Sometimes it's very fast, and sometimes it takes a little bit longer period of time. And in the meantime, while the patient is waiting for the CAR T cells to be prepared, usually they will need some type of therapy to make sure that their myeloma still stays in check before they're able to receive their CAR T cells back. So usually there's some standard of care therapy, which they call bridging therapy, will sort of bridge the patient along this period of time, which is, between 4 and 6 weeks between the time that their cells are taken from them and then the time that they actually get infusion. And then right before the infusion, the patient undergoes a procedure called lymphodepletion, which is, again, it's sort of similar to when a patient gets a stem cell transplant, where a patient will be given some stronger chemotherapy, which will deplete the number of white blood cells in their body. And then the infusion will take place. So the CAR T cells are infused back into the patient, and then they will begin to proliferate and then kill the myeloma cells. So it's a really sort of really interesting process. Any questions about that?
Well, Mary, I think there's a lot there. That's really important stuff. I want to quickly, I don't know how comfortable everyone feels with the immune system and the role that it plays in cancer. There are probably, there's a lot to talk about there and a lot to unpack.
Yes.
I can quickly just say one thing about it, which is that your immune system is not just, doesn't just go after foreign invaders like bacteria and viruses. It also can control cancer and can kill cancer. And one of the things that cancer first does when it first grows is figure out how to evade the immune system or even hijack the immune system. So all those different types of immunotherapies that Mary was referring to, they either prevent the immune system from hiding, so they uncover it and allow immune cells to move in and do their normal job, or in order to make them better, something like CAR T, they actually take the immune cells and genetically modify them, put them back, and so that they're better and they're more targeted to be able to bypass all the different ways that the myeloma will get around the immune system. So these are really ways of taking the way the immune system normally functions and bringing it back so that it's available and present to kill cancer cells. So it's really, really exciting work.
Yeah. No, that's great. And so, I was hoping that you weren't going to ask me to describe the immune system again, because immunology is very, very complicated. So, but the way you described it is really, sort of very on point for, the relationship between the immune system and cancer. And it's really just like you said, the way that cancer cells can hide from the immune system, because essentially cancer cells were normal cells before they became cancerous. So they actually look a lot like normal cells. So it's hard for the body to actually recognize them as being a problem and recognize them as being foreign. So that's really part of the difficulty. Okay, I'm going to move on here to.
Were there any other questions about CAR T? I know it's such an exciting.
Anything else?
And I didn't realize, Mary, that the FDA was that close to approving it. So that's super exciting.
It is very exciting.
It seems like there's a very vulnerable period of time as part of this CAR T cell therapy. I can't quite figure out how long, but a time when is someone isolated and to avoid any kind of infections?
During the time that they're infused? Yeah, so like after the lymphodepletion. So yes, it is actually the CAR T procedure is an inpatient procedure at this time. And once the patient undergoes the lymphodepletion and then the infusion, it's usually about 3 weeks, I think, that the patient will spend in the hospital to undergo the lymphodepletion and then the infusion, allow the CAR T cells to grow. And also an important part of that as well is to watch patients very carefully for some of the adverse events that can happen when the CAR T cells begin to work. So that's the reason why patients have to be in the hospital for that period of time, about 3 weeks before they're allowed to go home.
What happens to the red blood cells during that period?
I think the red blood cells are basically okay because the lymphodepletion is really just for the white blood cells. So the red blood cells should stay okay. I mean, in general, myeloma patients don't have hugely high blood counts because of all the therapeutics that they've gone through to sort of get to this point. But the CAR T cell therapy in and of itself does not affect the number.
Fascinating. Thank you.
Sure. Okay, so I'm going to try to quickly go to another slide.
Maybe while you're getting that up and running, perhaps I can talk a little bit about another form of therapy besides CAR T that's also pretty exciting, that's hopefully on the horizon, and that's something called bispecific antigens.
So that's just what I'm going to talk
Is
about.
this what you're going to get to? I figured it might be. Yep. Okay. Well, we're back.
Okay, good. So let me just.
There we go.
I'll put it in presentation mode, hopefully. Let's see if it'll work. I'm not going to start from the beginning. Okay, so I'm just going to go through it like this. Hopefully you guys can see the slide, right?
Yep.
Okay, perfect. I'm not going to go back into presentation mode. Okay, so there's other now types of antibodies that are useful in multiple myeloma. As I mentioned earlier, the naked antibodies, these are 3 antibodies that are already approved for myeloma: Darzalex, Sarclisa, and Implicity. They bind to the surface of myeloma cells and mark them so that the body can then recognize them as foreign and then kill them. So another new drug that was just very recently approved is the antibody drug conjugate belantamab mafodotin, which is actually called Blenrep now. So this is an antibody that has a cancer drug or toxin conjugated to it. So there's the antibody, and it actually has this cancer drug or toxin attached to it, so that when the antibody binds to the myeloma cell, it actually goes inside the cell and it takes the cancer drug or toxin with it. And when the toxin goes inside the cell, it will kill the cell. So it's a very specific way of killing myeloma cells with this antibody that has the drug conjugated to it. And then, as Dan was mentioning, the really exciting thing are these bispecific antibodies and bispecific T-cell engagers, or BiTEs. So these are 2 different constructs of antibodies that basically do the same thing. So a bispecific antibody looks like a regular antibody, but it has actually 2 different arms. And one arm, like the purple arm down there at the bottom, binds to the myeloma cell. And the orange arm at the top actually binds to a T cell. And in that way, it brings the T cell and the myeloma cell close together so that the T cell can kill the myeloma cell, very similar to what happens with the CAR T cell. A BiTE does essentially the same thing, but it looks a little bit different. It's actually a much smaller construct, and it has one end of it that binds to the myeloma cell, and the other end of the BiTE binds to the T cell. And again, it's bringing together into the same close space the myeloma cell and the T cell, so that the T cell then recognizes the myeloma cell and secretes those toxins to kill the myeloma cell. So these are some of these really exciting therapies right now. There's a number of these that are in the clinic, and patients can go on to these clinical trials. Really some sort of very exciting stuff. Any questions about these 2 things? So I'm not hearing anything, but so I will just sort of keep going here. I want to talk a little bit about precision medicine toward the end. I know that we don't have much time. So remember I talked about when plasma cells become cancerous, right? And what happens is that they mutate, right? So there are a number of different genes in plasma cells that change or mutate, and that helps to cause cancer. So there's been a number of these different genes that have been discovered in myeloma cells that actually change and are involved in the rapid and unnatural growth of these plasma cells that become myeloma cells. So there's these different pathways and different enzymes that are changed by these genomic alterations. They become much more active, and that drives the proliferation of these cancer cells and causes myeloma. So and different patients have different genomic alterations that might cause their specific cancer. Myeloma is different in every patient. Every patient has different types of genomic alterations that have caused their multiple myeloma. There's many different subtypes of myeloma, and that relates back to exactly which of these pathways have mutated. And finding out which pathways are mutated in each cancer patient is really precision medicine. And that's something that is really sort of near and dear to the heart of the Multiple Myeloma Research Foundation. We've been involved in precision medicine efforts for myeloma cells since we have been in existence as a foundation. So we've done a lot of precision medicine types of initiatives like sequencing the myeloma genome. And one of the things that we've done very recently is actually put together a trial called the MyDrug trial, which treats myeloma patients specifically with an agent that is that inhibits one of their mutations. So the way this trial works is that patients who are what we call functional high risk, which essentially means that they're newly diagnosed, they undergo therapy, but they relapse rather quickly. So they'll relapse within 18 months if they haven't had a stem cell transplant, or they relapse within 3 years of having a stem cell transplant. So these functional high-risk patients enter the study and they undergo DNA sequencing to look for the mutations or alterations that are present in their myeloma cells that might be contributing to how their cancer started. And then if an actionable mutation is found, then patients are put into the appropriate arm that has an agent that is targeted against that mutation. And these targeted agents, in many cases, are already approved to act against those mutations in other cancers, but they're not approved to be used in myeloma patients. So this is a clinical trial basically to look at the utility of these targeted agents in myeloma. So what happens is that patients, say for example, a patient has a mutation in the RAF or RAS pathway, they will receive this drug called cobimetinib, which is already approved in other types of cancer. And along with that targeted agent, they will also receive a standard of care triplet therapy that is known to be active in myeloma. In this case, it's the proteasome inhibitor Ninlaro, it's the immunomodulatory drug Pomalyst, and dexamethasone. So that's the IPD standard of care that the patients receive along with the cobimetinib. And there's a number of other pathways that we have targeted agents that we're testing in this trial. This type of trial is called an umbrella trial. So it has all these different arms that patients can go into. So, and then if patients are tested and they aren't found to have an actionable mutation, then they will go into another arm where they'll receive a monoclonal antibody such as Darzalex along with the standard of care agent. So this is really a novel type of trial for myeloma patients. It's the first umbrella trial that's taken place in myeloma. Another thing that we're doing in myeloma is working on the Cure Cloud, right? So the Cure Cloud is a direct-to-patient registry that we just started. And what we're doing in this registry is essentially we're allowing patients to enroll in the study. They can do that right on our website. And we're providing genomic sequencing to these patients so that we're looking through into their myeloma genomes and looking for actionable mutations. So I'm going to explain to you a little bit how this study works. And we just started it. We launched it fully back in July of last year. So patients can go onto the computer, onto our website and enroll in the study. And they just do it on the computer. And they have to have their physician fill out a form that will allow for a blood draw. So what happens when the physician fills out the form is that the MMRF sends a technician to their home and safely draws their blood. And the blood is used to examine their myeloma genome. And that's done by looking at myeloma DNA that is circulating in the blood. So normally when genomic testing is done, patients have to have a bone marrow aspirate done. So sticking a big needle into their bone and pulling out some cells, and then the cells are analyzed. But we're doing a very similar type of testing using a simple blood sample that's taken at patients' homes. At the same time, the patients sign a consent to allow us to collect all of their clinical information as well. And we have partner agencies that will go to every doctor at every hospital where the patient has been treated and collect all of their clinical information as well. So the patient undergoes genomic sequencing with a liquid biopsy. We collect all of their clinical information. And then this information is linked together and it is stored in our secure CureCloud database. So it really forms a very complete picture of each patient's myeloma, but it's de-identified so that no one knows what patient it belongs to, basically. So once the sequencing is done, the patients and their doctors will receive a report of the results of the sequencing. So the report will tell the patient and their doctor whether or not the patient has any actionable mutations, and it will report to them if there's an appropriate clinical trial that can be used to treat these patients based on their genomic sequencing. And also, the CureCloud allows a lot of data visualization. So all of the patient's data can be visualized in this visualization portal by the patient and also by their doctor. So basically what we're allowing through this is really forming a complete picture of the patient's myeloma and then making sure that both the patient and the doctor get the report of what the findings are so that the patient and the doctor can discuss it together and then decide what the best treatment plan might be for this patient moving forward. So, and at the same time, this data being securely stored is available for researchers, again, and this is really to accelerate cures for the entire myeloma community. And we're working toward enrolling 5,000 myeloma patients into this registry. So let me just summarize here really quickly. The myeloma field is really moving toward a genomic approach to staging people's myeloma and seeing whether or not they're a high-risk subtype or standard risk subtype. They're moving toward a 4-drug regimen in the front line, which can be more effective for patients who are considered to be high risk. We're looking into precision medicine and targeted therapies in different subsets of patients that are determined through genomic sequencing. We're looking at therapy that is driven by detection of minimal residual disease, which is really counting the number of cells that are left after induction therapy, for example, trying to minimize long-term toxicities because myeloma patients are really living much longer these days because we have had so many really effective new therapies approved, especially recently. And there's many new drug classes and immunotherapies available to patients now that are really going to be game-changing for myeloma patients. And really, we're hoping it's really going to move the needle to much longer survival and then hopefully a cure for this disease. So that's about what I have. And I know we're actually past time. Any questions?
Boy, that is very encouraging as well as just fascinating.
Yeah, it's a really an amazing field. And I have to say that there's just so much going on. There's just a lot of activity and lots of hope for myeloma patients. A lot of hope because there's a lot of really great new therapies that are in the pipeline.
What about consistent mutations? I mean, how long would one expect that one genomic test would be valid before there's enough change in the DNA that you'd have to have another genomic test and then another form of therapy?
Yes, I mean, that's a really excellent question. So even in the CureCloud, basically, patients need to have active disease in order to enter the study because they need to have a certain amount of myeloma DNA circulating that it can be detected and sequenced. So we're really looking at the DNA of patients who are newly diagnosed or relapsed. So if it's a newly diagnosed patient, we will provide sequencing for that patient. And then normally they would go into remission for a period of time. And then if their disease relapses and they're already in the cure cloud, we will certainly allow them to be take another sample and have them sequenced again. So essentially, patients should be sequenced each time they relapse so that the genomic landscape can be examined and defined with each relapse, so that that will help decide what the new therapy course might be.
Would it be helpful for me to give permission through my oncologist to contribute the bone assay results that were done at the beginning of my diagnostic and treatment plan?
So it doesn't matter. The cure cloud, it doesn't matter. If you want to join the cure cloud, if you're interested, you certainly don't have to be newly diagnosed to be able to enter. You can be relapsed. And we're also accepting a certain number of patients who have smoldering myeloma, which is a precursor condition to myeloma. So even if you're past the point of being newly diagnosed and maybe you're in remission now and you don't really have active disease, but that's okay. You know, if you ever relapse, we can certainly, have a sample taken and do the assay at that time.
So the blood assay would be comparable, congruent with the bone bioassay? It's
not quite it won't detect as many genomes. So normally, if we would do a genomic assay of what's in the bone marrow, it would be an assay that would analyze many, many different genes. The blood biopsy at this time only analyzes 70 genes, which is not a huge number, but we're also in development of a much better and much more comprehensive blood assay. And in the near future, we're going to be able to detect many, many more alterations. So at this time, it's not as sensitive, the blood assay is not as useful or as sensitive as the bone marrow assay, but it will detect certain actionable mutations and any patient can get it. It's free charge to any patient.
And Phil, the other thing you have to remember is that the assay that you had done a few years ago, because you've probably received treatments, the cancer is continuously changing. So the number of mutations that it has changes over time. And let's say that, a certain population of cells gets killed by one of your treatments, other mutations may come in and grow up. So the question you asked is really, really important, that if in the clinical trial that Mary's talking about, if someone gets a drug for one pathway and the cancer becomes immune to it, can they get the drug for the next pathway? And it sounds like, Mary, the answer is yes, that they can continuously get retested so that as the cancer changes, they can get treated with new drugs.
Yes,
that's absolutely. A really, really cool trial.
Yeah, great work. I was so excited for Mary to share the Cure Cloud information with us. And I do know also, we ran out of time, so she couldn't mention it, but there are also just patient resources that the MMRF offers, things like Patient Navigation Center and also a mentor program, which is really great, outside of the science, more of, support, connection, things like that. All in all, MMRF is doing great things, and I'm so glad you could join us, Mary. I did also want to mention that Gryt Health has, we have something called the Gryt Project. So we also do research here at Gryt Health. So not, we're not doing clinical trials and, in the lab type of research, but we do patient engagement, kind of talking about your experience. Research, which is also super important when treatments are being created. Things like that information of, hey, it would be really terrible to keep having to go get blood draws. Well, MMRF probably listened to patients and said, well, heck, we'll send someone up to your house. And so research, hearing about your experience as a survivor and a patient is really important. And Gryt Health actually has an open study that's active that we're taking people for multiple myeloma. So you can visit the website I just dropped, or you can email projects@grythealth.com to see if you're eligible. Again, it's just a conversation, learning about your experience and what you've been through. And Jessica dropped that link as well. This has been really great. I do see, Mary, do you have time for one more question? I see Robert has his hand. Okay, Robert.
Sure.
Yes. Are you recommending with each relapse, you're supposed to get another biopsy?
I think that certainly when patients relapse, there's a number of reasons to get a biopsy. First of all, it really helps to determine what the disease burden is at the time of relapse, which can be important in determining what therapy the patient might go on next. And as well, the doctor would be wanting to look at the cells that are in the bone marrow. And not every doctor will do genomic sequencing on your cells, but they will at least look at your cells, look at cytogenetic, and do some FISH testing, some fluorescence in situ hybridization to look for certain chromosomal deletions or rearrangements that might tell your doctor a little bit more about the subtype in this relapse, a little bit more about whether the subtype of this relapse is maybe a higher risk subtype than what was previously seen before the relapse. And that would also inform the next treatment decision. But sequencing is also a really great way to get that information.
Thank you.
Great, thank you. So I know there were a couple other questions and just surrounding information, but like I said, tonight was recorded. And I'm also going to go back through the chat, make sure we covered things. And if we didn't cover certain questions, I'll go back and figure those out. I'll also follow up with Mary, her and I on the side through email.
Sure. Mm-hmm.
Just, I know some of you guys have asked about the slides and, how to contact Mary and MMRF. So what I always do after program is send an email out to you guys in the next week or so, just kind of summarizing and things like that. So I will get all of the things together and put them in my follow-up email for everyone. And I see Darcy actually dropped a different link for the project that Gryt Health is doing, so that's there too. And I'll include that in my email as well as more information about the Cure Cloud for those of you that want to sign up for that. So thank you again, everyone, for joining. I learned a lot, and I'm sure everyone else did too. It was very informative.
Good.
Thank you again, Mary, for being with us and
Sure.
helping us acknowledge March as Multiple Myeloma Awareness Month.
Yes, certainly my pleasure to be here. And thanks everybody for coming. And thanks for the invitation. Really enjoyed it. So, and please don't hesitate to, I know that Lauren has my contact information. If you have questions or anything, please don't hesitate to email me and, we'll take care of whatever you need. And if you want to be connected to the Patient Navigation Center, I can help with that too. So, okay.
Great. Thank you, everyone. I hope you have a great night.